Welcome to the Rad-Onc Smart Review GU Cancer Series.
Glad to be here. We have a really great topic today.
Yeah, we do. So today, for episode 17, we are focusing on metastatic urothelial cancer.
Right.
Specifically, we're getting into immunotherapy or IO and really looking at the future directions of this whole space.
Because it is just changing so incredibly fast.
Oh, absolutely.
Yeah.
I mean, I want you, the residents listening right now, to really visualize the biological reality of this disease. For decades, metastatic urothelial cancer was just relentless.
Yeah, unforgiving.
Truly. It's this highly mutated, aggressive malignancy. It just rapidly exploits the lymphatic and vascular highways of the pelvis, right?
Right, creating these visceral beachheads in the liver, the lungs, the bones.
Exactly. And historically, when a patient presented with those distant mets, we had exactly one reliable weapon.
Platinum-based chemotherapy.
Right. We would push them to the absolute brink of their physiological tolerance. Dose-dense MVAC or gemcitabine and cisplatin.
Yeah, and if we were incredibly lucky, and I mean really lucky, we might buy them a median overall survival hovering right around, what, 14 or 15 months?
Right. Yeah. That was the platinum ceiling. You'd hit it, and you just could not break through.
No, you couldn't.
But the reason we're doing this deep dive today is because that platinum ceiling has finally shattered.
It really has. I mean, it's difficult to overstate the magnitude of this paradigm shift. We have witnessed a complete rewriting of the foundational rules we all learned in our training.
Yeah, the days of accepting a 14-month median survival are over.
Thank goodness. And the catalyst for this disruption is the EV302 trial.
Right, the big one.
Yeah, the trial that firmly established the combination of enfortumab vedotin plus pembrolizumab EV-pembro as the preferred frontline regimen for really the vast majority of these patients.
And it wasn't just a marginal win, right?
Oh, not at all.
Yeah.
This isn't one of those trials where we are, squinting at a Kaplan-Meier curve trying to find a 2-week survival benefit to justify some massive price tag.
Right.
This is a staggering, practice-altering improvement. It won by a lot in progression-free survival, overall survival, and response rate.
And that profound systemic efficacy creates a really fascinating ripple effect for those of us in radiation oncology.
Absolutely.
So the mission of our episode today is really twofold. First, you need a highly granular understanding of this rapidly changing systemic landscape.
Because you cannot participate intelligently in a modern GU tumor board without it.
Exactly. You just can't. And second, and arguably more crucially for us, we have to define exactly where the radiation oncologist fits into the puzzle now.
Because we are rarely the main event up front anymore.
Right. When the medical oncologists have a weapon this powerful, our role shifts. We have to know precisely when to deploy our tools, to salvage local control or palliate symptoms.
Without interfering with the systemic master plan.
Exactly. So to ground all of this in reality, we're going to use a clinical case anchor that we'll continuously reference throughout the discussion.
Sounds good.
So I want you to imagine a 68-year-old man sitting in your consultation room.
Okay.
He brings a 30-pack-year smoking history, which is obviously the classic dominant environmental risk factor driving that high mutational burden.
Right, the classic presentation.
Yeah. And his initial presentation to urology was for gross painless hematuria.
Which is the textbook red flag. I mean, painless hematuria in a heavy smoker is urothelial carcinoma until proven absolutely otherwise.
Right. And the lack of pain is insidious, really, because it often delays the patient from seeking care until the bleeding becomes alarming.
Exactly. So what do they find?
Well, he undergoes a cystoscopy, and it reveals a large, sessile, broad-based mass occupying the left lateral wall of the bladder.
Okay.
So the urologist takes him to the OR for a TURBT, a transurethral resection of the bladder tumor. The pathology comes back confirming high-grade urothelial carcinoma.
Right. And do we have muscle in the specimen?
We do. The detrusor muscle is present, and it is overtly invaded by the tumor.
Ah, okay. So we have definitive muscle-invasive disease.
Yes, we do.
Which means the staging paradigm immediately shifts. You're no longer just thinking about the bladder. You have to assume the disease has microscopic, if not macroscopic, access to the systemic circulation.
Exactly. So he undergoes full cross-sectional staging, a CT scan of the chest, abdomen, and pelvis with IV contrast.
And what does that show?
Well, it highlights the bulky primary bladder mass, but as we follow the scan up into the abdomen, the radiologist notes two distinct hypervascular suspicious lesions in the right lobe of the liver.
Oh, man.
Yeah. One measures 1.8 centimeters and the other measures 2.4 centimeters.
And the bones?
A technetium 99-meter bone scan is also obtained. Unfortunately, it is completely negative for osseous metastatic disease.
Okay, well, that's something. But based on the liver involvement, we are dealing with AJCC stage IVB disease right out of the gate.
Right, stage IVB. But I want to pause on this workup for a second, because this is where residents often import habits from other disease sites that, frankly, don't belong in GU oncology.
Oh, yeah, the brain MRI question.
Yes, exactly. Let's look at the baseline data. We have a heavy smoker with an aggressive high-grade histology and documented visceral metastasis in the liver.
Right.
If this were a primary lung adenocarcinoma or, I don't know, a high-risk melanoma, my absolute next reflex would be to order a dedicated MRI of the brain with contrast.
Naturally.
Right, to rule out asymptomatic intracranial metastasis before initiating any major systemic plan. But with liver mets in urothelial cancer, shouldn't we automatically get a brain MRI too?
Yeah, it's a great question, but the answer is no. That is a highly relevant clinical distinction.
Why is that?
The biology of urothelial carcinoma just dictates a different imaging strategy. I mean, while this disease certainly can and does metastasize to the central nervous system, it does so at a significantly lower frequency in the asymptomatic upfront setting.
Right, compared to, like, small cell lung cancer.
Exactly. The incidence of occult brain metastases at initial presentation is simply not high enough to justify the cost, the time, and, the potential for false positives.
That makes sense.
Yeah, especially in patients who have a completely normal neurological examination. Brain imaging in urothelial cancer is strictly symptom-directed.
So if he had a headache...
Right. If our 68-year-old gentleman reported a subtle new morning headache, a change in his visual fields, or any focal deficit, then we would immediately order that brain MRI with gadolinium contrast.
Okay, got it. So strictly symptom-directed. That distinction is incredibly important for the boards and just for practical resource management in the clinic.
Absolutely.
Now, let's look at his physiological reserve. Because in this disease space, the patient's baseline fitness is the lens through which every single treatment decision is filtered.
It really is. So how is our guy doing?
He's actually doing pretty well. His ECOG performance status is a solid 1. He's fully ambulatory, capable of all self-care.
Okay, great.
We check his renal function, and his calculated creatinine clearance is 65 milliliters per minute.
Okay, good to know.
We do a thorough review of systems and physical exam. His hearing is perfectly intact, he has no baseline peripheral neuropathy, and his cardiac history is unremarkable. Normal ejection fraction.
Wow, okay.
He does have a long-standing history of type 2 diabetes, but he is compliant with his metformin, and his most recent hemoglobin A1C is well controlled at 6.4.
Okay, that A1C is going to be important later.
Definitely. And just to complete the diagnostic loop, IR performs a core needle biopsy of the larger liver lesion, and pathology confirms metastatic urothelial carcinoma.
Matches the bladder primary.
Exactly. We've also sent the tissue out for comprehensive next-generation sequencing, and the specific test for an FGFR alteration is currently pending.
Okay, so the clinical picture you just painted is comprehensive, but there's an underlying current here that we need to address head-on.
What's that?
Well, you carefully detailed his creatinine clearance at 65 milliliters per minute, his intact hearing, his lack of neuropathy.
Right.
These are the classic textbook criteria we use to determine if a patient is, quote-unquote, cisplatin fit.
Yeah, exactly.
But we just established moments ago that enfortumab vedotin plus pembrolizumab, a regimen that contains exactly 0 milligrams of cisplatin, is the new dominant frontline standard.
I know exactly where you're going with this. Why do we still obsess over calculating the creatinine clearance and checking hearing if we are just going to put them on EV-Pembro anyway?
Right. It feels like we are clinging to a relic of the past, doesn't it?
It really does. So why do we care?
Because understanding cisplatin fitness remains a critical, non-negotiable step in your clinical pathway. Oncology is a discipline of contingencies.
Ah, okay. The backup plan.
Exactly. You must always know the architecture of your backup plan before you deploy your primary weapon. EV-Pembro is phenomenally effective, but it is not universally tolerated.
Right.
And it's not always available due to specific contraindications we'll discuss. If a patient cannot safely receive EV-Pembro, the entire treatment algorithm bifurcates based entirely on whether they can handle cisplatin.
So we review the classic reasons for cisplatin ineligibility.
Yeah, the Galsky criteria. Impaired renal function, specifically a creatinine clearance less than 60 milliliters per minute.
Okay, ours is 65.
Right. poor performance status of ECOG 2 or worse, grade 2 or higher baseline peripheral neuropathy,
Right.
grade 2 or higher baseline hearing loss, given the ototoxicity of the platinum agents, or significant heart failure, like New York Heart Association class 3 or 4.
So even in the era of antibody-drug conjugates, you cannot navigate this disease without explicitly defining your patient's cisplatin status on day one.
You have to know the foundational tracks before you can route the train.
Right. And speaking of the train, let's get into the mechanics of the frontline systemic revolution. You brought up the EV302 trial. Let's really unpack that.
Okay, let's do it.
Because to use these drugs safely, you have to understand exactly how they work. Emphasize that enfortumab vedotin plus pembrolizumab didn't just win, it won by a lot.
It crushed the historical standard. EV302 was the global phase 3 randomized trial. They took previously untreated, locally advanced or metastatic patients and randomized them.
EV-pembro versus platinum-based chemo.
Exactly. Gemcitabine with either cisplatin or carboplatin. The median overall survival for the chemo arm was around 16 months.
Which perfectly aligned with decades of historical data.
Right. But the median overall survival for the EV-pembro arm nearly doubled that. It came in at over 31 months.
Over 31 months. That is incredible.
Progression-free survival doubled too, and the objective response rates approached 70%.
Wow.
Yeah, with nearly 30% achieving a complete response, meaning the macroscopic disease completely disappeared on imaging.
Those numbers are just staggering. But it's the mechanism behind the numbers that I find so elegant. We're moving away from, the blunt instrument of systemic chemo
Oh, yeah.
and into the era of precision payloads. Enfortumab vedotin is an antibody-drug conjugate. Let's break that down for the listener.
Yeah, let's do it.
So the antibody portion is a fully human monoclonal antibody directed against Nectin-4.
Right. Nectin-4 is a cell adhesion molecule. It's highly, almost universally overexpressed on the surface of urothelial cancer cells.
But it has relatively minimal expression on normal, healthy tissue.
Exactly. So the antibody acts as a highly specific homing beacon. It seeks out the bladder cancer cells circulating in the body.
And once that antibody binds to the Nectin-4 receptor on the surface of the tumor cell, the entire antibody receptor complex is rapidly internalized into the cell through endocytosis.
Right, it pulls it inside.
And once inside the acidic environment of the lysosome, the linker molecule that connects the antibody to the drug payload is cleaved.
And that releases the highly potent cytotoxic agent directly into the cytoplasm of the cancer cell.
And this is where the specific biology of the payload becomes critical for understanding the toxicities we see in the clinic.
Yeah, absolutely.
The payload in enfortumab vedotin is a drug called MMAE, which stands for monomethyl auristatin E.
MMAE.
MMAE is a synthetic agent that is incredibly toxic. So toxic, in fact, that it cannot be given systemically on its own.
It would be universally fatal.
Exactly.
Mhm.
It's a microtubule inhibitor. Once released inside the cell, MMAE binds to tubulin and completely disrupts the microtubule network.
And microtubules are those structural cables that a cell uses to pull its chromosomes apart during mitosis.
Right. So by destroying these cables, MMAE arrests the cancer cell in the G2M phase of the cell cycle, which leads to rapid catastrophic apoptosis.
It destroys the tumor from the inside out, and while it's doing that, the pembrolizumab is simultaneously working on the tumor microenvironment.
Right, the other half of the combination.
Yeah, pembrolizumab is an immune checkpoint inhibitor, specifically a monoclonal antibody against PD-1 found on our circulating T cells.
Because urothelial cancer cells are notoriously clever, right?
Very. They upregulate a ligand called PD-L1, which binds to the PD-1 receptor on the T cell, sending an inhibitory off signal.
It paralyzes the immune system.
Right. So pembrolizumab blocks that interaction. It lifts the brakes off the T cells and allows them to recognize and attack the cancer cells.
The synergy between the targeted cytotoxic strike of the EV and the immune activation of the pembro is just. It's what drives those unprecedented survival curves.
Exactly.
I often use a specific analogy to help residents conceptualize this regimen. Think of EV Pembro as a state-of-the-art, incredibly powerful high-speed train.
Okay, I like that.
It's the fastest preferred way to get the disease under control. But because the train is so heavy and moves so fast, you can only put the patient on board if the tracks, meaning their baseline physiological reserve, are really solid.
Oh, that's a great way to think about it.
If the tracks are compromised, putting them on that high-speed train will result in a catastrophic derailment in the form of severe toxicities.
The high-speed train analogy is perfect because we really have to spend significant time defining what constitutes bad tracks.
Right. What are the bad tracks for EV?
Well, because MMAE is a microtubule inhibitor, its effects are not entirely confined to the cancer cell. Microtubules are essential for axonal transport in our long peripheral nerves.
Ah, right.
The nerve endings need microtubules to transport vital proteins from the cell body down the axon. When the MMAE payload inevitably leaks into the systemic circulation, it impairs that transport.
Effectively starving the distal nerve endings.
Exactly. And this leads to profound sensory and motor peripheral neuropathy.
So a patient with severe pre-existing baseline neuropathy, say from severe diabetes or prior neurotoxic chemo, has compromised tracks.
Severely compromised. Giving them EV Pembro could render them completely wheelchair-bound or unable to button their own shirt. Severe baseline neuropathy makes EV a highly unattractive, often contraindicated option.
Okay, let's apply that directly to our 68-year-old case anchor. We noted in his history that he has type 2 diabetes.
Right.
He's currently managed on metformin, and his hemoglobin A1C is 6.4. How does his diabetic history factor into our assessment of his tracks?
Yeah.
Does that A1C of 6.4 derail the EV Pembro plan?
No, it does not derail the plan, but it requires a high degree of clinical vigilance.
Okay, why?
This is a critical nuance. Controlled diabetes, as evidenced by his excellent A1C of 6.4, is an acceptable baseline. He can absolutely proceed. However, enfortumab vedotin is infamous for causing severe, rapid-onset hyperglycemia.
Really? Even if their diabetes is well controlled?
Yes. In fact, it can occur even in patients who have zero prior history of diabetes or glucose intolerance.
Wow.
The exact mechanism is still being elucidated, but it's thought to be a direct toxic effect on the pancreatic beta cells, or it induces profound peripheral insulin resistance. We have seen patients develop life-threatening diabetic ketoacidosis, or DKA, after just 1 or 2 doses.
That's terrifying.
It is. So while his well-controlled diabetes is not an absolute contraindication, it's a significant risk factor. We are going to monitor his fasting blood glucose before every single infusion.
Right. But what if his A1C had been like 10.5?
If his A1C was 10.5 and his daily blood sugars were persistently in the 300s, that would constitute bad tracks. We would have a serious debate about whether the high-speed train is safe.
Because the risk of precipitating a fatal metabolic crisis might outweigh the oncologic benefit.
Precisely.
That is exactly the kind of sophisticated risk-benefit analysis you need to demonstrate. To help you synthesize and memorize the unique toxicity profile of enfortumab vedotin, I want to share a highly effective mnemonic.
Excellent. Residents love a good mnemonic.
When you think of the side effects of EV, I want you to immediately think of the word SHIN. That's SHIN. Let's walk through what each letter represents, because these are guaranteed to show up on your exams.
Let's break it down. The S in SHIN stands for skin toxicity. The Nectin-4 target is heavily expressed in the skin, particularly in the epidermis and the hair follicles. When the antibody drug conjugate attacks the skin, you see a wide spectrum of dermatologic events.
Ranging from a mild maculopapular rash to severe pruritus.
Or even life-threatening cutaneous reactions like Stevens-Johnson syndrome or toxic epidermal necrolysis involving widespread blistering. You must do a thorough skin exam before every dose.
Crucial. Then the H stands for the hyperglycemia we just discussed in depth. Rapid elevations in blood glucose that can escalate to ketoacidosis.
Yep. Then the I stands for interstitial lung disease, or pneumonitis.
Okay.
This is a non-infectious inflammation of the lung parenchyma. It presents with a new dry cough, progressive dyspnea on exertion, or just asymptomatic ground glass opacities on a CT scan.
And if you see signs of pneumonitis,
You must hold the drug, initiate a high-dose corticosteroid taper, and consult pulmonology immediately.
Right. And finally, the N stands for the neuropathy. Because of that MMAE payload disrupting microtubule transport, patients develop a symmetric stocking glove sensory neuropathy.
Numbness, tingling, and pain in their fingers and toes. And if it progresses to motor neuropathy, presenting as discal weakness or foot drop, that is a severe dose-limiting toxicity.
So lock that mnemonic in: SHIN skin, hyperglycemia, interstitial lung disease, and neuropathy.
And we cannot forget that EV is only half of the equation.
Right. Pembro.
Pembrolizumab carries its own well-documented spectrum of immune-related adverse events.
The classic IO toxicities.
Exactly. By taking the brakes off the immune system, you risk inducing a generalized autoimmune syndrome, We are constantly monitoring for the classic itises.
Thyroid dysfunction, pneumonitis, hepatitis, colitis, dermatitis.
Right. Severe colitis presenting as massive volumes of watery diarrhea, or immune-mediated pneumonitis, which can compound the interstitial lung disease risk from the EV.
It's a lot to manage. The complexity of managing these overlapping toxicity profiles requires a highly coordinated, vigilant, multidisciplinary team.
But the survival curves prove that the rigorous monitoring is undeniably worth it.
Absolutely. The high-speed train is the standard of care. But, as we promised earlier, oncology is about contingencies. We need to clearly define our alternative pathways.
Yes, the backup plans.
So what if our patient couldn't take the high-speed train? What if EV-pembro wasn't an option? Say he had terrible, debilitating baseline peripheral neuropathy from decades of poorly controlled diabetes.
Or a severe underlying autoimmune disorder like active rheumatoid arthritis or lupus that made the use of pembrolizumab an absolute contraindication.
Exactly. What is the next logical step in the algorithm?
This specific scenario highlights exactly why we calculated his creatinine clearance during the initial workup. If EV-pembro is removed from the table, we immediately revert to assessing his cisplatin fitness.
And we know our case anchor has a creatinine clearance of 65 milliliters per minute. He's ECOG 1. He is definitively fit for cisplatin.
Right, so for a cisplatin-eligible patient who cannot receive EV-pembro, the Phase 3 evidence-based alternative comes from the CheckMate 901 trial.
All right, CheckMate 901. I really appreciate the design of this trial because it elegantly bridges the gap between our historical platinum backbone and modern immunotherapy. Can you walk us through the mechanics of that regimen?
Absolutely. The CheckMate 901 trial asked, can we improve upon the historical standard of gemcitabine and cisplatin by adding an immune checkpoint inhibitor right from day one?
And they used nivolumab.
Yes, nivolumab, another highly effective monoclonal antibody targeting the PD-1 receptor. In this regimen, the patient receives concurrent therapy. They get intravenous gemcitabine and cisplatin alongside intravenous nivolumab for up to 6 cycles.
So the chemo acts as a massive cytoreductive hammer.
Exactly, rapidly debulking the tumor and inducing cancer cell death, which releases a flood of neoantigens into the tumor microenvironment.
And the concurrent nivolumab is there to ensure the immune system recognizes those newly exposed antigens.
Right, mounting a robust T-cell response. But the most critical phase happens after those 6 cycles are complete. If the patient has not progressed, they transition to receiving nivolumab continuation therapy as a single agent.
Maintaining the immune pressure on any residual microscopic disease.
Right. And this concurrent followed by continuation approach demonstrated statistically significant improvements in survival compared to chemo alone. So, CheckMate 901 is your definitive backup plan here.
That sequence is logical and clearly supported by the data. But let's look at another highly common scenario. This routinely trips up residents, both in the clinic and during their oral board examinations.
The maintenance trap.
The maintenance trap.
Yeah.
Let's say we have a patient who cannot receive EV-pembro and also cannot receive the concurrent CheckMate 901 regimen. They're treated with the historical approach. 4 to 6 cycles of standard frontline platinum-based chemotherapy.
Gemcitabine and cisplatin if they're fit, or gemcitabine and carboplatin if they have renal impairment.
Right? They power through the chemo. We bring them in for their post-treatment restaging CT scans, and the imaging shows stable disease. The primary tumor hasn't shrunk dramatically. Lymph nodes are the same size, but importantly, nothing has grown. Here's the trap question. If they get 4 to 6 cycles and the scans show stable disease, can we just give them a drug holiday, observe, and restart at progression?
Yes. The oral boards trap. I am thrilled you set up that scenario. The answer is a definitive, categorical no.
No drug holiday.
You do not observe. If a patient receives frontline platinum-based chemotherapy and their post-treatment scans show either a partial response, a complete response, or merely stable disease, it is considered a mandatory standard of care to offer them a volumab switch maintenance therapy in that immediate post-chemo window.
Right. Based on the Javelin Bladder 100 trial.
Exactly. Do not wait for progression.
Let's dissect the underlying radiobiology and immunology that makes this maintenance principle work. Why is it a mistake to wait for progression?
The biological rationale is absolutely fascinating. When you give 4 to 6 cycles of platinum chemo, the drugs do the heavy lifting of macroscopic cytoreduction. They kill off a massive volume of the rapidly dividing cancer cells.
Undergoing immunogenic cell death, releasing a vast array of unique tumor antigens.
Right, but standard chemo is a double-edged sword. It causes profound systemic tissue damage and transient immunosuppression. If you simply stop all treatment and wait,
The small population of residual chemoresistant microscopic clones will inevitably exploit that recovery period.
They will regroup, proliferate, and eventually present as macroscopic progression months later. And by the time you can see that progression on a CT scan, the disease burden is high, the tumor microenvironment is immunosuppressive again, and your window has closed.
Which is where avelumab comes in.
Exactly. Avelumab is a monoclonal antibody that targets PD-L1. By introducing avelumab switch maintenance immediately after the chemotherapy phase, you strike while the iron is hot. The disease burden is at its absolute nadir, the tumor antigens have been freshly exposed, and you are providing a powerful checkpoint inhibitor to wake up the immune system.
It trains the T cells to hunt down those residual chemoresistant clones.
The Javelin trial proved beyond any doubt that utilizing this switch maintenance strategy significantly prolongs overall survival compared to observation. Do not wait for progression.
It makes the necessity of the maintenance strategy abundantly clear. So we've mapped out the EV-Pembro route, the Checkmate 901 route, and the Javelin-Avelumab route. Let's briefly address the absolute extremes of the fitness spectrum.
The truly platinum ineligible.
Right. Their renal function is so poor that neither cisplatin nor carboplatin can be administered safely. If they also cannot receive EV-Pembro, what is the strategy?
For that specific, highly vulnerable demographic, pembrolizumab monotherapy remains a valid FDA-approved frontline option in the United States. It provides a critical, potentially effective therapy with a tolerable safety profile for patients who would otherwise have no options.
And conversely, what if a patient presents with a severe, uncontrolled autoimmune disease? IO is completely contraindicated. Where do we turn?
When checkpoint inhibitors are an absolute contraindication, you must rely entirely on the historical standards. Your fallback is traditional platinum-based chemotherapy alone. You give the chemotherapy, and you accept that switch maintenance immunotherapy is unfortunately not an option for them.
Right. You fight the disease with the tools the patient's physiology permits. Now, before we close the chapter on the frontline landscape, I want to emphasize a very specific cleanup point for our listeners.
The atezolizumab warning.
Yes. Over the past several years, there has been a complex, shifting narrative regarding atezolizumab in the frontline setting. I want to firmly, unequivocally advise you, do not volunteer atezolizumab as a routine, standard upfront U.S. option in your current board answers.
I fully endorse that advice. Your goal on an exam is not to recite the entire historical encyclopedia of withdrawn or amended indications. Stick to the EV-Pembro preferred pathway, Checkmate 901, or Javelin. Keep your answers clean, defensible, and strictly aligned with current data.
Exactly. Okay, let's progress the timeline of our case anchor and move into Section 4. Later line sequencing and molecularly targeted therapies.
Moving the timeline forward.
Yeah, so our patient is on EV-Pembro. He tolerated the high-speed train beautifully, enjoyed 14 months of excellent disease control. But unfortunately, on his 15-month restaging CT scan, the clinical picture changes. Both liver lesions are definitively enlarging, and the radiologist notes a new hypermetabolic 2-centimeter lymph node in the retroperitoneum. The EV-Pembro regimen had unequivocally stopped working. What's the next move?
This specific juncture is where the meticulous initial workup pays dividends. Remember that core needle biopsy we obtained from the liver metastasis at the very beginning of the case?
Yes, we sent that tissue for comprehensive next-generation sequencing, and the FGFR testing was pending.
Let's assume that report has now finalized, and it reveals that his tumor harbors a susceptible mutation in the FGFR3 gene.
FGFR stands for fibroblast growth factor receptor.
Correct. The biology here is crucial. In roughly 15 to 20% of all metastatic urothelial carcinomas, a genetic alteration occurs in the FGFR3 gene. This alteration creates an aberrant, constitutively active receptor tyrosine kinase.
It acts as a powerful oncogenic driver, constantly signaling the cancer cell to proliferate. It's essentially a gas pedal that is permanently stuck to the floor.
I love that. Yes, a stuck gas pedal. And if we can identify that specific stuck pedal, we can deploy a targeted molecular wrench to fix it.
Which opens the door for erdafitinib.
Exactly. Erdafitinib is a highly potent, orally administered pan-FGFR tyrosine kinase inhibitor. By binding to and inhibiting the intracellular kinase domain of the mutated receptor, erdafitinib effectively shuts off that constant proliferation signal.
So for our patient who progressed on EV-Pembro, this is a highly logical, targeted next step.
Right.
But let's change the scenario. If only 15 to 20% of patients have this alteration, what about the 80% who do not? Let's say his NGS report comes back entirely wild type for FGFR. How do we determine the sequencing logic now?
The sequencing logic relies entirely on tracking the mechanisms of action the patient has already been exposed to. Let's review his history. He received enfortumab vedotin, a microtubule inhibitor. He received pembrolizumab, an immune checkpoint inhibitor.
What is glaringly absent? He's entirely platinum naive.
Exactly. His tumor cells have never been exposed to the DNA cross-linking damage of cisplatin or carboplatin. Because we bypass chemotherapy in the frontline setting, traditional platinum-based chemotherapy, such as gemcitabine and cisplatin, becomes a highly appropriate standard option in the second-line setting.
We have essentially taken the historical algorithm and flipped it completely upside down.
We really have.
It's a profound shift. However, I want to acknowledge an observation. It feels like the post-E sequence isn't fully settled yet.
Sure.
We know what to use first, but the optimal combinations, the precise ordering of second, third, and fourth-line therapies, it still feels a bit like uncharted territory.
I share that exact sentiment. The rapid adoption of EV-Pembro essentially outpaced the clinical trial infrastructure for subsequent lines of therapy. We have a massive vacuum of prospective, randomized data telling us exactly what the best sequence is after EV fails.
So what do we do?
Because the standard of care is fluid, our default reflex must always center on clinical research. Whenever a patient experiences disease progression on EV-Pembro, the very first question raised in tumor boards should be, do we have a clinical trial available for them?
Enrollment should remain front and center. I couldn't agree more. And I need to make one more explicit cleanup point regarding systemic options.
Sacituzumab govitecan.
Yes. You will inevitably encounter data regarding sacituzumab govitecan. It targets TROP2 and delivers an SN38 payload. While it has demonstrated activity, I strongly caution you against volunteering it as a routine, standard current option on your board examinations.
Right. Do not try to outsmart the exam by quoting shifting, controversial data. Anchor your answers in the most robust, established principles. FGFR3 alterations unlock erdafitinib, utilize platinum if platinum naive, and actively seek clinical trials.
Exactly. Okay, we have spent a considerable amount of time mapping the systemic biology. Now, it is time to bring the focus back to our own house in Section 5, the radiation oncologist's playbook.
My favorite part.
With all these incredible drugs, where do we actually fit into this patient's journey? Let's start by looking back at the very beginning of our case anchor. Documented intact primary bladder tumor, but no significant local symptoms. Asymptomatic liver metastases. Does this patient require upfront radiation therapy to the bladder to secure local control before starting systemic treatment?
The answer to that question is a short, unequivocal, and absolute no.
No upfront radiation.
Right. For a patient presenting with de novo asymptomatic metastatic urothelial carcinoma, there is zero routine role for upfront definitive or palliative radiation therapy to the primary tumor. You have to respect the biology of the presentation. The presence of those liver metastases dictates that the immediate overriding priority is systemic therapy.
EV-Pembro must lead the charge. I consistently tell residents that knowing exactly when not to offer radiation is vital, but urothelial cancer is notorious for being a messy, physically devastating disease. We are absolutely going to get caught.
Oh, we will definitely be consulted.
So let's structurally break down the 3 key consults where RT shines. What is the first and arguably most urgent scenario?
The first key consult is for severe bleeding and local pelvic symptoms.
Right. Gross hematuria.
Exactly. Despite the efficacy of modern systemic therapies, they take time to work. These patients often have massive necrotic tumors ulcerating the mucosal surface. They can develop severe, relentless, gross hematuria requiring continuous bladder irrigation and blood transfusions.
Or severe bladder spasms and intractable pelvic pain.
In these desperate situations, palliative radiation therapy to the bladder is highly effective. The goal is entirely focused on rapid hemostasis and symptom relief.
What specific dosing regimens do we rely on?
The dosing strategy is wonderfully pragmatic. The 2 most common workhorse regimens we utilize are 20 gray delivered in 5 daily fractions or 30 gray delivered over 10 daily fractions.
And if they have a really poor performance status?
You might consider shorter fractionations, like a single fraction of 8 gray. But the 20 gray and 5 fractions regimen is incredibly reliable. We aren't just killing cancer cells. The radiation induces rapid endothelial cell swelling within the tumor microvasculature.
It promotes localized platelet aggregation and capillary thrombosis, clotting off the bleeding vessels from the inside out.
It's deeply satisfying because the relief is tangible. But we must be honest about the acute toxicities. You must warn them about an exacerbation of baseline urinary irritation, increased frequency, urgency, dysuria.
And bowel bother, right?
Yeah, loose stools or mild proctitis. But it's manageable.
Okay, that's consult number 1. What's the second key consult?
Painful osseous metastases. When this disease seeds the bones, it typically produces highly destructive reticulitic lesions. This causes intense pain and increases the risk of a pathologic fracture. Palliative radiation is unequivocally the gold standard for rapid pain relief.
Focus on bone meds. We rely on the classic palliative fractionations. 8 gray in 1 fraction, 20 gray in 5 fractions, or 30 gray in 10 fractions. A single 8 gray fraction is an incredibly elegant and potent intervention, especially to minimize their time at the hospital.
Absolutely. The radiation profoundly alters the cellular microenvironment, inhibiting osteoclasts and reducing inflammatory cytokines.
It works, and it improves quality of life. But now, consult number 3.
Oligoprogression.
Let's return to our case anchor. He's been on EV Pembro for 12 solid months. Phenomenal response. Primary bladder mass undetectable. 1 liver lesion vanished, the other reduced to 1 centimeter.
Okay, sounds great so far.
But on his 13-month scan, that residual 1 centimeter lesion has suddenly grown back to 2.5 centimeter. Every other site is pristine. We have this one rogue resistant clone. So if a patient has 1 growing liver met while on ED Pembro, do we automatically pull out the SBRT?
You perfectly highlighted the clinical tension. The immediate temptation is to say, yes, absolutely, let's aggressively zap that single resistant spot. But you cannot, under any circumstances, allow your thought process regarding SBRT for oligoprogression to sound automatic or reflexive. It is an incredibly complex, highly selected decision.
I want to push back on that. If a patient has 1 growing liver met, why shouldn't it be automatic? We have the technology to deliver ablative SBRT to that resistant tumor and eradicate it. What is the downside?
The downside is the illusion of oligoprogression. What appears on our CT or PET scans as a single isolated spot is frequently just the macroscopic vanguard of a much broader systemic wave of resistance. By the time that liver lesion evades EV Pembro, there are likely thousands of microscopic clones disseminating throughout the lungs and bones that have acquired the exact same resistance mechanisms.
They just haven't proliferated to a detectable size yet.
Right. If we reflexively zap that one spot with SBRT, we subject the patient to the toxicity of radiating the liver, only to scan them 3 months later and find their lungs riddled with new metastases. We treated the tip of the iceberg.
That is a sobering perspective.
However, there is absolutely a role in the right patient. In a meticulously selected individual long period of disease control, demonstrably isolated progression, then yes, metastasis-directed therapy utilizing SBRT becomes a powerful strategy. We treat the progressing lesion and keep the effective systemic therapy going, but do not overstate the evidence.
Right. It's a highly selected, multidisciplinary decision. That distinction is the hallmark of an expert clinician. All right, it is time to shift gears into session 6, the board blitz and clinical pearls. Let's start with the 60-second board script.
Right.
You are sitting across from an examiner. They hand you our case anchor vignette.
Yeah.
Stage IVB, cisplatin eligible, no IO contraindication. Give me the perfect, safe, sayable board answer.
This is a patient presenting with de novo metastatic urothelial carcinoma of the bladder with documented liver metastases, representing AJCC stage IVB disease. Crucially, I note that he is cisplatin eligible and has no obvious contraindications to immunotherapy. Based on the EV302 data, my preferred first-line systemic therapy is the combination of enfortumab vedotin plus pembrolizumab. A reasonable alternative is checkmate 901 nivolumab plus gemcitabine cisplatin. If he receives standard platinum and achieves stable disease, offering avelumab switch maintenance is the mandatory standard of care. I would not recommend upfront definitive or palliative radiation to the primary tumor. I would reserve radiation therapy for the symptomatic palliation of gross hematuria, painful osseous metastases, or highly selected oligoprogressive disease after a rigorous multidisciplinary tumor board review.
That is an absolutely bulletproof response. Now let's execute a rapid review. I'm going to fire 3 distinct clinical scenarios at you. I want your immediate reflexive thought process. Scenario 1, newly diagnosed, good renal function, no neuropathy, no autoimmune history, preferred regimen.
EV Pembro. The tracks are clear. Put them on the high-speed train.
Excellent. Scenario 2, patient completes gemcitabine carboplatin with stable disease. Next step.
Immediate initiation of avelumab switch maintenance therapy. Do not observe.
Perfect. Scenario 3, enlarging solitary met on systemic therapy while the rest is controlled. Thought process.
Multidisciplinary discussion to evaluate for the illusion of oligoprogression. If selected, consider metastasis-directed therapy, like SBRT, while continuing the active systemic regimen.
Flawless logic. That covers the absolute most critical concepts. As we transition to our conclusion, I want to briefly reflect on how dramatically the field has changed from the era of platinum-only sealings to nuanced IO and targeted sequencing.
It is truly staggering. We can look a patient in the eye and offer them genuine hope for durable responses that we simply did not have 5 or 10 years ago.
Which perfectly sets the stage for a final provocative thought. Where is our field headed next?
I believe the greatest intellectual challenge for the next generation of GU oncologists won't be the first line, but mapping out the uncharted territory of sequencing targeted therapies and radiation after EV-Pembro fails, and particularly using circulating tumor DNA, or ctDNA. If a patient receives EV-Pembro, their scans are clear, but their ctDNA remains positive. Do we deploy consolidative radiation to the primary bladder tumor to eradicate the residual DNA? That intersection of ultrasensitive molecular diagnostics and targeted radiation therapy will define the next major leap.
That is an incredibly compelling vision for the future. Complete practice oral boards at radoncsmartlearn.com and subscribe to Radonc Smart Review for our next episode. Thanks for tuning in.